Yeah, good evening all. Welcome to the panel discussion on pain management in cancer. I welcome my eminent panelist, Dr. P.N. Jain, who is Professor of Palliative Medicine at Tata Memorial Hospital, Mumbai. Dr. Aju Matthew, who is Consultant Medical Oncologist at Ernakulam Medical Center, Kochi. Dr. Seema Mishra, Professor of Department of Oncoanesthesia and Palliative Medicine at IRCH AIMS. Dr. Amod Manocha from Pain Management Services. He's heading the Pain Management Services at Max Hospital, Delhi. And Dr. Swati Bhatt, Director of Pain Services at Bangalore. She is also a Senior Consultant in Onco Pain at City Care Hospitals, Bangalore. So as we all know that pain in cancer patients is complex and can be extremely debilitating. Incidence is as high as 90% in patients with advanced cancers.
The PPT is not visible.
No, I've not made a PPT.
Okay.
I'm just having a discussion with our faculty. So there's no PPT for this presentation, and audience can place their questions in chat box. So we all know that incidence of pain is pretty high in advanced cancers, and most of the patients in our setting get diagnosed late in their course of illness. So pain management becomes an eminent part of their cancer care. And goal of this panel discussion is not to teach you about or educate you about pain management. It is more about how we can apply these pain management guidelines in our setting. So my first question is to Dr. Matthew. Sir, I would like to ask you, in your experience, how important is to manage pain in cancer patients when you diagnose these patients and during their treatment? And how do you integrate the management of cancer pain in your cancer care?
Yeah, thank you, Dr. Damani. One of the most commonest symptoms of patients with cancer is pain. And an oncologist or a cancer doctor cannot practice cancer care without knowing how to treat pain. At least that's what I believe. So it's always assumed that one should be able to learn.
Dr. Matthew, I think there is some problem with your network. I'll come back to you in a few minutes. May I proceed with asking a question to another panelist? Sir, I'll get back to you on your previous question. Moving on, I would like to ask Dr. Jain. Sir, we have discussed about current guidelines available for cancer pain. I would like to ask you, since we had evidence that these guidelines are not really applicable or it is opinions of experts, how do you really apply these guidelines in managing cancer patients at your setting?
These are the general guidelines laid down by the WHO, because we have published about 7 guidelines in Indian context, but there were not sufficient studies, Indian studies, on which we can base our own Indian context guidelines. So generally we are going by the WHO guidelines, and WHO guidelines are saying that it is by the mouth, by the clock, and for the individual, and with attention to the details. These are the 4 things which have been given by the WHO 2018 guidelines, right? So we have to give the tablet only. So it is oral analgesic, which are the actually just a baseline, and which are the most important point. So many patients come to us that we take daily injections, and that gives accident relief. Many of our patients are getting over-the-counter diclofenac injections daily. So that those myths of Indian context, like injections work better. So those things have to be ameliorated from their mind, or should be cleared from their mind, that injections are not important, because serum concentrations of the drugs are better maintained by oral analgesics when they are given. When the drug dose is receding in effect, the next dose should be given. So oral morphine has been found to be still the gold standard for cancer pain, and every 4 hourly the drug should be given by the clock, by the mouth, by the clock. So ideally, on a paper, when the patient wakes up, when the patient sleeps, So on according to that, his schedule, so that is attention to the detail. So that those should be those doses should be jotted down on the paper and should be told to them that this is very important to stick to the schedule, not to stick to their pain schedule. Mostly patients I see in 80% of our OPD patients, they are taking the drug by the severity of pain. When the pain is very severe, they take morphine tablet and they say now it is not working. So your treatment is not working. So first thing first, we should ask them, when are you taking the tablet? So always I tell in the OPD that you take the tablet of morphine at 7 a.m. when you first wake up and without coming out of the bed. On empty stomach, in second concept is, in Indian context is that they think that all the tablets should be taken after the breakfast. So somebody is waking up late, like 9 a.m., and then they take the tablet at 11 a.m., and they go into severe pain, and that morphine tablet is insufficient to control that pain. So that should be cleared from their mind. So I say that at 7 a.m., when you wake up, you take that tablet, wait for 1 hour to act, because all our preparations are actually 40 to 60 minutes onset time. When you are painless, then come out of the bed, go for daily chorus, start brushing your teeth, go to the toilet, and then go for the breakfast. By the time you are absolutely comfortable. And for the individual, so we have to assess patient. What type of pain is this? Whether it is neuropathic pain, whether it is arising from the bone metastasis, whether it is arising from something else. So according to that, morphine is not the panacea. Okay. So we have to see that what type of pain is it, whether movement is causing pain. So all these things. If the patient is having bone metastasis predominantly, then of course radiotherapy has to be given. Bisphosphonates have to be given sometimes. Steroids should be given, and sometimes all proper adjuvant should be given. All the time laxative should be given with morphine. So these are the general guidelines for effective
Thank
pain
you, sir.
management.
So,
Thank you.
Jen sir just now mentioned that WHO ladder, which was actually initially published in 1986, still holds a lot of value in our pain management in cancer patients. I would like to ask Dr. Mishra, ma'am, can you please tell us about more about WHO ladder, whether there are any riders to use of WHO ladder in cancer pain patients and where we should deviate from the ladder?
Thank you, Anuja. As Dr. Jan has really mentioned about WHO and energetic ladder, and I feel it still holds a great value in our cancer pain in day-to-day daily life. Especially in our country where the low resources are there, still it is the best one which we can take. But definitely there's a ways where we have the policies are there where we have to modify it, because this ladder when it has been published in 1986 and then almost in 22 languages it has been published. But the reason is that it was really for chronic pain. It has not mentioned anything when patient have a acute and chronic pain like that. What should be done it? So that was the more concern it that we can say that was no regime it was written that how we have to go about it, because all oral medications obviously by this time we know that oral medication is not going to be used to use, especially the patient have a chronic acute pain. So that was the one reason that some modification, various modifications are being proposed that what we should do there. The data should be that when the patient has acute pain, then we should start, do not wait for step 1 to go up to 3. Instead, we can go up to 4 also, like intervention, we can, especially that patient, the head neck patient. They have very severe neuropathic pain. So waiting for the step ladder to go for ladder 3 and keep on having the drugs, especially that head neck patient, they have neuropathic pain, whereas the opioid role is having limitations. In that context, that all the, if the expertise are available, intervention should be the first choice. So this is one of the, you can say that lacking is there where we can propose it, and now we are applying is also in day-to-day activity. Wherever the facility or the skills are there available in that context. Another is like those pain, those are not any non-cancer pain, especially the fibromyalgia and all, where we cannot wait for those again step ladder 2 and 3 like this, where a lot of addiction potential. If you suppose the patient is having severe pain and we start the opioids without thinking of CDC guidelines, so there's a chances that in non-malignant pain, it's not going to be very useful in that. Another is those patients where we have to think, like in the first letter, we have given NSAID, lot of emphasis we have given for NSAIDs. It shows that we are placing that drug in the step 1, that is the safest drug. But when you say the NSAID, it is not the safest one, especially when as a adjuvant we take these drugs in routines. Suppose the patient every letter we can take this drug, but we are taking the drugs opioid with an NSAID for a longer time. What is the side effects where the patient are going to have it? You can think the renal impairment. Obviously, one way we are going on to treat the pain part, but simultaneously we are adding the adverse effects on the NSAIDs. So we really have to think about whether it is going to be really justified in subgroup of the patient where already the patient has renal impairment, how to judiciously use that ladders. Whenever we use any step 1 ladder, it is always in our mind, this is the safest drugs, which is not there, especially in non-malignant pain. Also, you can say the rheumatoid arthritis and all, where they cannot take the patient for a longer time. So these are some of the concepts where we can have to really change in that consult. And one more thing, this ladder is basically based on severity of pain. But by this time, we know the pain is not a one dimension. It's a multiple dimensions. The pain is only the physical dimension which we are measuring it. So we are forgetting the other component, which is much more important, and we have to really address it. So this is, I think, it was started in Leva in 86, where the aim was to give the best pain for the cancer pain, and that's so much awareness has gone. Started with that. Now we are thinking that pain is not a physical one. So that is one of the biggest problem in that context. That's why now we are assessing the pain as a whole, multidimensional. So it is not pain intensity, other component also we have to think about. These are some of the, I think, fallacies which can be improvised in proposed different sets of that.
Thank you, ma'am. I think that is very well said by ma'am, that pain is not only physical, there is a total pain component to cancer pain. I would like to ask Dr. Amod, sir, can you please tell us more about how do we address this multiple dimensions of cancer pain in a patient with cancer, and how do you integrate your multidisciplinary team to manage this multiple aspects of cancer pain?
Thank you, Anuja, for that question. Can you hear me? Am I audible clearly?
Yes, sir.
Great. So I think, Anuja, we've got a very learned audience, and I think the best way I could go about it is by maybe giving an example. So I'll probably discuss a case. So I'm reminded of this lady from my time in UK. And I remember it was just just when you're about to go on a weekend off, the last case you see, which is the one which sticks in your head. But anyway, so this young Asian lady was there, and I was asked to see her because there were communication issues with the language barrier and stuff. So they thought probably me being an Asian would be able to do a better job over there. So I went and saw this lady, and she was a young lady, Asian origin, with a small child lying next to her. And I was in a hurry to go home, and I asked her, where do you have pain? So she replied, from head to toe. And I was like, the first reaction was, it's not going to be an easy consultation. I'm sitting there for a long time. But anyways, a little did I know about her. So she took her little time to open up, and then she started telling her story. So I'll say that in brief. So she she had a difficult pregnancy, as in like they tried a long time before they could conceive, and she went for a delivery, being the happiest woman in the world. She, as she says, this was her own words, that I went into that operation theater for a cesarean section thinking I'm the happiest person and I'm going to come back with a happy baby. And my life changed when I came back. So essentially during the cesarean, they found that she had a tumor in her pelvis, and her life changed from there. So this was when I was seeing her was about a year later. And by that time, her husband had left her. got tired of the the cancer and the treatment and the financial pressures and the baby and the other implications which were happening. So he went and settled with another English lady. She was almost about to be kicked out of her job because it was a private enterprise with little protection. So she was almost about to leave her job, lose her job. She was evicted of her house, and thankfully the social services in that setup take care of you. She had a house, but not as good as it was before. Being an outsider, she had to call her parents from India who came to help her, but they were old, crumbly. Little did they know about the system over there, and they were struggling with their own health issues. Then on top of that, she had this young little one who was always crying, and the guilt feeling which comes with it. I can't breastfeed, I can't look after the child, and then the other worries which were there in her head. That she was in advanced cancer, and she didn't know how long she's going to live, and then who's going to look after the child, and is God punishing me for something I've done wrong? Why does this happen to me? I've struggled so much. So it was a very emotional next half an hour, 45 minutes. And anyone, I've just summarized everything very briefly, but if you sat through that conversation, I can bet anyone would be in tears. That's how was the emotional component. From being the most happy person, you're like in pain. Physical pain in this whole scenario was minimal. There was some discomfort around the surgical site, but then there was this concept of total pain, which I think if I can't find a better example to describe the total pain. There's every component in there, from social to psychological to the physical to the spiritual. Every component is very, very evident, and the physical component, which I had to identify these components and put in place whatever was required, but the actual medicines and the management of the physical pain was hardly required. And that brings us to the concept of the multidisciplinary team and the management of such patients and what role they can play. I was thinking about where does this concept come from, and I think the key reasons for having an MDT is, number one, is the skill. None of us have the skills to address all these different components, right? There might be a few lucky ones like Cicely Saunders, who actually came out with this total pain concept, who had experience in multiple domains. But then most of us are just too focused into our narrow little streams and not in a position to address all these components. Then I thought further, and I thought, other problem is time. How much time do we have to assess each of these individual components, right? What justice can we do even if we had the skills? How much time would that take? Do we have the interpersonal skills? Do we have standard assessment parameters which we can kind of gauge them with? So this is where the multidisciplinary team concept comes from, where each and different members, they have different roles and they have different skill set they bring to the whole scenario. And the whole aim is to address each and every component and give the best holistic care we can. And that's the concept of total pain in the MDT. As I can describe in the best possible way.
Thank you, Dr. Amod. I think that is put really nicely by you by giving an example, and it really is the scenario when we deal actually with cancer patients. But to the other side of it, I would like to ask Dr. Bhatt. Ma'am, we just saw the evidence for intervention pain management, and some patients, although many patients would respond to pharmacological treatment, but some patients are those who will need intervention. I would like to ask you that is it feasible to offer interventions in advanced cancer patients? And what would be the helpful interventions that we can ask for from an intervention pain specialist?
Yeah, thank you, Anuja, for that question. Yeah, definitely. As you would have already, we have already heard from Dr. Naveen in his talk. He did mention about the recommendation levels. So as he mentioned that celiac plexus procedures like celiac plexus, vertebroplasty, and intrathecal drug delivery system, they hold a level 1A evidence, which means very, very strong evidenced procedures for relieving cancer pain. So I not only believe, but I have my clinical practice and clinical experience to say, definitely patients do require these procedures, as well as they benefit very, very strongly from such interventions. I've had experience of patients who I have put on intrathecal drug delivery, like morphine pumps, and they have outlasted the kind of time span which was probably indicated for their life expectancy. And not only have they been off the radiotherapy or the chemotherapy, but they also started, when we placed the intrathecal pumps on them, they started feeling very well. So we could see signs of, I wouldn't say reversal, but the quality of life definitely improved in such patients. So definitely in even advanced cancer patients, interventions do hold its very, very important place. And I would really suggest or say here that we do, the earlier or the intermediate guideline was to have, in the WHO step ladder, was to have introduced the interventions as a later on step. But we very, very strongly potentiate that there should be a sixth ladder step, the WHO ladder, wherein the interventions should be brought at the earliest phase, where the patients would rather not go on medical therapy at all, but are straight away put on intervention, and very early in course of time, they can benefit from these procedures. When you hold procedures like vertebroplasty or splanchnic nerve ablations, etc., they last for at least a year and a half for such a patient, and the pain is very, very well controlled with these in such group of patients.
Thank you, ma'am. I think interventions do play a role in management of cancer patients. Now, I'm coming back to Dr. Aju, our medical oncologist on the panel. Sir, we've seen WHO ladder, multidisciplinary pain management, some riders to the ladder, and interventions. So much to do with cancer pain. As you earlier mentioned, that you don't have a specialist palliative medicine physician in your setting. How do you apply all this as a medical oncologist to your practice? This is my last question, sir. And if you can just tell us, how do you do this?
Briefly, I'm trained in palliative medicine through my fellowship. I think most oncologists get some training, but not too much. I have assistance from Pallium India for help that I require that goes beyond my expertise. They do virtual online consultations that with my patients. So for the basic requirement, I have the training that I require to help patients with pain. A lot of my colleagues do not have access to morphine. We conducted an online course to equip oncologists, practicing oncologists on pain management, and certified them over 8 weeks. And about 78 oncologists across India have completed that. So that has also been done. So that's briefly an answer to your question. How do I practice, manage? Sort of based on my experience, learning through fellowship, and partly with experts who are available at the beck of a call.
Thank you, sir. I think it's important that everybody who is dealing with cancer patients have basic education in pain management, as we all can understand from what Dr. Matthew is highlighting. And pain management is variable. It's right from beginning with pharmacological treatment to a lot of interventions coming up in pain management in cancer. So I think having that individualistic approach and individualized approach to each cancer patient is very important. By that, I'll summarize the discussion and end it there. If there are any questions in the chat, Ame, are there any questions?
No, ma'am, there's no question.
Okay, so thank you to all my panelists here. Thank you, Dr. Jain, Dr. Anuja, Dr. Mishra, Dr. Matthew, and Dr. Bhatt for such wonderful discussion that we had today.
Thank you very much.
Thank you, Amey, for the session.